Good afternoon and good morning, ladies and gentlemen. Welcome to the webinar of Management of Lower Limb Tumor with Endoprosthesis today. My name is P.Q. Wu. I am the chief in the Therapeutic and Research Center of Musculoskeletal Tumor in Taipei Veterans General Hospital in Taiwan. On behalf of the organizing committee, I would like to welcome all of you to this online webinar. It is our privilege to have you with us. Today, we have 5 talks about the treatment of lower limb tumor. Dr. Fauzi, who is the head of Department of Orthopedics and Traumatology of Cipto Mangunkusumo Hospital in Indonesia. Dr. Fauzi also came to Taipei Veterans General Hospital several years ago, and we had really great cooperation experience then and very great dinner. Today, the title of his talk is Limb Salvage Surgery with United and Other Implants, the outcome and the challenges in treating advanced bone tumor cases. Dr. Fauzi, please say hello to our audience.
Thank you, Dr. Wu. Good afternoon from Jakarta. Assalamualaikum warahmatullahi wabarakatuh. Nice to meet you all. Thank you for inviting me, Dr. Wu, organizing committee, and also from the United Implant.
Thank you, Dr. Fauzi. And another speaker, Professor Sin, who is the head and faculty of Department of Orthopedic Surgery in University of Malaysia. Professor Sin will be sharing with us the tips and the tricks in endoprosthesis replacement. Professor Sin, please say hello to our audience.
Good afternoon, everybody. It's nice to be part of this webinar.
Okay, thanks, Professor Sin. And Dr. Nori, who is an orthopedic surgery specialized in both knee and hip surgery. It is our privilege to have him today sharing his experience with in primary bone tumor from Tunisia. And I have been told that he has done several cases of USTAR 2. Looking forward to seeing the clinical outcome from Dr. Nori. And Dr. Nori, please say hello to our audience.
Hi, everybody. Good morning. Assalamu alaikum. A warm welcome from Tunisia. I'm very happy to be part of this panel of honorable surgeons.
Okay, thank you, Dr. Nori. And we also have Dr. Matt Liu here. Dr. Liu has worked in orthopedic implant research and development field for more than 15 years. He will tell us the design advantage of United USTAR 2 system. Matt, please say hello to our audience.
Hello, everyone. Thanks for joining the webinar. Hope you really enjoy today's presentation. Thank you.
Okay, thank you. And all 5 speakers will participate timely throughout the whole session to ensure a smooth event. The pre-recorded speeches will be displayed, and all speakers will be ready to take questions from the audience during the panel discussion. So if you want to raise questions, please type the question in the chat room. Okay, so now I'm going to give you my talk. My experience in bone prosthesis composite for sarcoma around the knee. Thank you. Good afternoon, ladies and gentlemen. I would like to thank the United team for inviting me to share my experience with BPC for sarcoma around the knee. It is a great honor to present today, especially in the company of my esteemed colleague, Dr. KAMAL, Dr. Nori, and Dr. Sin. Over the past decade, we have done BPC by freezing or irradiated recycled autograft with Zimmer rotating hinge knee for sarcoma around the knee. To date, we have accumulated over 200 cases. As seen in our paper published in JOA 2015, reconstruction using the RHK showed excellent MSTS functional score and low complication rate. Patient with high-grade malignancy around the knee. In another paper published in Core 2018, both methods show great radiographic results and excellent graft survival rate. This patient was a parosteal osteosarcoma over the distal femur. Nowadays, we prefer perform pedicle freezing by freezing tank, which could prevent from osteotomy. This clip introduces freezing tank. We dissect the tumor as usual and wrap the tumor-bearing bone without perform osteotomy into the freezing tank, then freezing by liquid nitrogen. After freezing and thawing, we augment the freezing bone by osteosynthesis. So for this lady, after freezing and thawing process, we perform bone prosthetic composite with Zimmer RHK with plate augmentation. We can see after 4 days of the surgery, the patient was ambulating without a cistern in the ward. At 10 days, he had already traveled to Korea, and at 4 months, she was back to premorbid status. Compared to traditional freezing methods, the patient's recovery is so quick. This method is not limited to young patients. As you can see in our 55 years old patient with the UPS of the distal femur. Again, we did pedicle freezing by freezing tank and RHK reconstruction. The patient can immediately weight bearing and regain full range of motion with no evidence of tumor recurrence at 30 years of follow-up. And so overall, from our previous experience with Zimmer RHK has provided satisfactory results. However, we have identified 2 limitations. The next 3 cases demonstrate our first concern with the Zimmer RHK, which is the size of the distal femur cut. This is a 44 years old patient with NPC with solitary bone metastasis. We can see from the MRI that is a significant metadiaphysis region has been compromised. After pedicle freezing with freezing tank, we now have to consider the type of RHK to use. If we had opted for the rotating hinge knee, it meant jeopardizing more sizable width and depth for the intercondyle cut, which may cause poor bone structure over epimetaphysis area. The case 2 presents a similar dilemma. In this 31 years old with recurrent giant cell tumor, we can see that the lesion caused extensive bony destruction on the epimetaphysis with significant soft tissue extension. Following Y excision, we proceeded with pedicle freezing by freezing tank. But again, if we had opted to use the hinge knee system, huge bone resection by intercondyle cutting and posterior condyle cutting may jeopardize the bony structure. and the last case demonstrates similar concern during revision surgery. In this patient with distal femur osteosarcoma, the X-ray showed pathology fracture and collapse of the lateral metaphyseal area, as well as extensive osteoarticular involvement. So after pedicle freezing, we used allograft to augment the bone defect and perform ligament repair. While initial result was promising, and the knee appeared to be stable throughout range of motion during intraoperative testing. However, after 2 years of follow-up, the reconstruct ligament are failure, and the knee show instability. So for the revision by rotating hinge knee was scheduled for this patient in order to address the knee instability. And due to the poor bone quality, the procedure of the surgery should minimize the bone loss. Some of you may ask now, how significant is the difference between the distal femur cut of the Zimmer HK versus United USTAR system? For the Zimmer HK, the standard width of the bone cut is 26 mm, while the depth range from the 19 to 27.5. In contrast, the USTAR 2 system preserves more bone, particularly at the intercondyle width. And this seemingly small difference of 2 to 5 mm can be quite significant in bone tumor surgery, especially for those poor bone stock over meta-epiphysis area. In addition, the smaller built-in hinge also means a smaller amount of bone to be resected, not just at the femur intercondyle, but also the distal condyle, posterior condyle, and tibial side. Compared to other hinge knee, USTAR 2 preserve more bone stock compared to Zimmer and Smith and Nephew. So due to the above benefit, the United RHK system were used for all 3 cases. For the NPC solitary metastasis, after pedicle freezing, we assembled USTAR 2 hinge knee system and augmented by a single plate. By the 5 days post-op, he was ambulating without any assistance. The patient's recovery is so quick. For the second case of recurrent giant cell tumor, after pedicle freezing, the USTAR 2 hinge knee system were applied. And we can see his ambulation status at 2 months post-surgery. Besides, the knee range of motion is so great. Finally, we have the revision surgery for ligament failure. After revision by USTAR 2, using 2 side plate for augmentation, here's the patient ambulating with a walker at 6 weeks post-op. So we know United USTAR 2 provides smaller bony resection, allowing for more preservation of the native bone. And it do help for tumor surgery. And the next unmet need is related to option for the femur stem. Here I present a case of non-union after free freezing. This is a 17-year-old lady diagnosed with distal femur osteosarcoma extending 14 centimeters into the diaphysis. After free freezing, which means we cut off a bone and freezing, we use Zimmer RHK with 12 times 155 stem, which is the longest stem available in Taiwan. However, from the post-op X-ray, we can see that a longer stem by passing the line of osteotomy would be better. Not surprisingly, non-union occurs at 5 months post-op. We address this by adding a second plate on the medial side and the osteotomy union a couple months later. So, if a longer stem available in the initial surgery, or if we apply dual plate, maybe we could prevent from these complications. The table shows the stem size available in Taiwan market. We could see the stem provided by United is full range of spec. Even we can order a custom-made stem. And one benefit most to us is the smaller diameter with a longer stem, because as we know, the sarcoma is usually occurred in kids and teenagers. The next case is a great example. This lady is a 16-year-old osteosarcoma over distal femur. Tumor is 18 centimeters, extensive into diaphysis. After performing pedicle freezing by freezing tank, due to no osteotomy performed, we augmented with a single side plate and used suture anchor to perform ligament reconstruction. However, as you can see in this comparison X-ray, at 3 years post-op, the subchondral bone was resorption and collapse. So to improve the function, we plan to perform revision surgery by hinged system knee. Here is a photo showing defect on the articular. And it is meaningful to see the subchondral bone here is oozing during the revision surgery, which means the freezing recycled bone is revascularization. So go back to planning the revision surgery. How to choose the stem? We should take something for consideration. First, the patient is a teenager and a girl, so the stem size should be less than 40 millimeters. Second, this is an osteoblastic type osteosarcoma. The bone quality is very tough. That means the bone canal is so difficult to perform reaming. So we have to prepare smaller stem as we expected. Third, because the tumor length is 18 centimeters, so we need a longer stem to pass the tumor. The selection of implant, including the plate and the stem, is more restricted in free freezing than in pedicle freezing due to osteotomy. Once we have osteotomy, we need more rigid fixation to gain bone union. To acquire a rigid fixation, we need a dual plate for free freezing. However, single plate should be okay enough for pedicle freezing. For free freezing, it is better to apply a longer stem to pass the osteotomy compared with pedicle freezing. Lastly, the patient's femur bone is bowing, So we need to prepare a curved stem as well. So in conclusion, before the surgery, we need to check we have all the stem we want. Small diameter, long enough, both straight and curved. Finally, we'll choose 12 times 150 millimeter curved stem for this lady. And we thanks United prepare all sized stem for us. So during the surgery, we can worry free. Finally, I want to share a case with pedicle freezing and United USTAR 2.
Moderator 有吗？帮你给我。你蹦蹦咯。照个相。5.7怎么办？都不要去挤。刚好。对。打洞就可以了。3号来。box 应该做 box 啊，对，这样子啊，这样没错吧？换个位置，录下去啊，对啊，是这一个嘛，对啊，对啊。不用，再下去啊。来黑吗？要运到。你要12的吗？好，用12。好，真品上了。这个给你了。To conclude, advantage of United USTAR 2 over Zimmer's HK include smaller bony resection, allowing for more preservation of native bone, and a wider selection of stem size options. Caveat to this are the lack of long-term follow-up. We would be happy to share our additional experience for USTAR 2 over the coming years. And thank you for your attention.
Good afternoon, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh from Indonesia. Thank you, Moderator Professor P.K. Wu, and also the organizing committee from United, Mr. Jason Lin, Mr. Thomas, to invite me to share a small experience about limb salvage surgery with the United and other implants in our hospital. This is our hospital. Cipto Mangunkusumo Hospital is located in Jakarta, top referral hospital, especially for west part of Indonesia, teaching hospital from Faculty of Medicine Universitas Indonesia. This slide is actually sweet memory I attached to the Professor Shi in Changgang Memorial Hospital and Professor Lee in 2013, and I visited the Veteran General Hospital attached to my best friend, Professor Wei Ming Chen, in 2014. And this is actually the Indonesia is a nation of island comprised of more than 13,000 islands around the equator. It encompasses the largest national territory and populations in the Asian member states, and right now is the fourth largest populations in the world. So we have the 12 faculty of medicines and also related to the teaching hospital, which has the orthopedic oncologists to give services for the musculoskeletal tumor patients from the Aceh, North Sumatra, Padang, almost big cities in the Java, including Jakarta, and also the Makassar and Banjarmasin, South Kalimantan. So regarding the geographic of course, that in its health challenges in its healthcare system because of the geographic barriers. So many patients comes to the hospital, our hospital or other hospitals lately because of the one of the problem is geographic barriers. These cases actually examples of the patients comes very lately to our hospitals. Yeah, so in this case, of course, we have to do ablations. Yeah, so because that the ulcerations very extensive of the soft tissue, so no health tissue including around of the tumor. So the challenges in the health system musculoskeletal tumor, not only because of the geographic barriers, but because of the traditional helper or the things about the bones setter first, or what kinds of the problem, pain around of the joint, yeah, or swelling around of the joint. So there are things about the sprain, socioeconomic problems, even though that since 2008, so our government give the insurance for the poor people, Jamkesmas, and since 2014, our government provide the universal health coverage for the all people in Indonesia. This is the history of limb salvage surgery in our hospital. Since 2094, we perform the biological reconstructions, extracorporeal irradiations, small cases with the massive allograft from the tissue bank Surabaya, Dr. Sutomo Surabaya Hospital, and free vascularized fibular graft, and also the cryosurgery with the liquid nitrogens. We initiated since 2018 until now. 2010, we performed the composite between the biological reconstruction, extracorporeal irradiations, and endoprosthesis. And 2011, the megaprosthesis was initiated, especially from the United distributors, and almost patients actually covered by the universal health coverage for free. But there is the problem in the end of 2014, so we have to look for another alternative implant. 2015, so actually most cases are actually this implant paid by the patients. So at least we have performed more than 16 cases by myself. This samples is actually osteosarcoma in a 12-year-old girl had the limb salpage surgery with the ECI technique. This is the foredistal femur osteosarcoma. After the completely clinical and imaging, we performed the pineal aspirations biopsy. We discussed with the clinical pathological conference. After we confirmed that it is the osteosarcoma, neoadjuvant chemotherapy was performed, and after that, we did the salpage surgery and block resection had been done, trimming of the tumor and sends this bone to the nuclear installations agency for extracorporeal irradiations. And for the next day, we perform the reconstruct with the implantations of this bone, and we fix it with the ORIBs. This actually girl, she has been surviving 14 years after surgery follow-up, and right now she is a social worker for the osteosarcoma patients community. So we view actually for the 15 years periods, we had the more than 900 cases. So we more than the 57% primary tumor malignancy and 30% benign aggressive bone tumor, and around 11% metastatic bone disease, and 60% we performed salpage surgery and the remaining for limb ablations. So fortunately, even though we late from the other countries in the world, so we performed the salpage surgery with the megaprosthesis 2011, and after that, the many hospitals in Indonesia also performed the megaprosthesis for reconstruction of bone defect in limb salpage surgery. This case, in our hospital with the distal femur osteosarcoma in 15 years old girl. So after we perform the neoadjuvant chemotherapy, so we see that the clinical and radiological result after neoadjuvant will produce response to neoadjuvant chemotherapy. So after that, we decided to do salpage surgery with the united implant for distal femur. After end-block resections, we reconstruct the bone defect with these implants, and this is the 2 years follow-up after surgery. She could perform the daily activity even though there is the lack of the flexions of the knee after surgery. This case actually patients with the universal health coverage as well, using the united implant for the proximal tibia giant cell tumor. So after confirm the diagnosis, we decided to do the end-block resections and reconstruct with the proximal tibia implants, and after that we perform the soft tissue coverage with the medial gastrocnemius flap and reattach the patellar tendon to the implant and reinforce with the reattach the patellar tendon to the medial gastrocnemius flap to improve the functions of the extensor mechanisms. This is the proximal femur metastatic bone disease, actually with the pathological fracture caused by the nasopharyngeal cancers. So this is the first time the patients consult to us with the grossly swellings of the lower extremities. This is the imaging with the pathological fracture. This is the MRI. No other lesions in the other bones. So we decided to do the neoadjuvant chemotherapy. So this is the clinical picture after chemotherapy. The grossly swelling subsides. So we decided to do after that and block resection of the proximal femur and reconstructs with the proximal femur implants. This is the result from our collecting data. We have the 32 cases with the megaprosthesis from the united implants, with the 15 cases giant cell tumor, 14 osteosarcoma, 2 cases of the metastatic bone disease, and another one with another case. So the location, in terms of the locations of the tumor, of the tumors, 15 tumors are located in distal femur, 13 are tumors are located in the proximal tibia, and 4 cases in the proximal femur. So we review the oncologic outcome, the local recurrence, complications, and metastasis, and also we review the functional outcome with the MSTS score. This is the MSTS scores. Actually, in the 3 months postoperatively, some patient has the various functional outcome from poor, more hair until good, but most cases had the fair functional outcomes. So, but from time to time, the functional outcome should be better from fair, good, and excellent. And after 12 months post-operatively, almost cases has the excellent functional outcome. The remaining cases are good function outcome with the MSTS score. So, but how about the complications after surgery, limb salvage surgery with the megaprosthesis? One case should be amputated because of the ischemic limb after surgery, and one case the dislocations of the implants, and some cases with the limb length discrepancy, proximal tibia reconstruction is longer than normal size. 3 patients died during follow-ups, 2 cases of the osteosarcoma because of the metastasis, and 1 case from the brain metastasis from nasopharyngeal carcinoma, and also worsening sepsis. This our case with the vascular compromise because of the vascular injury. This patient actually why the patient had because of the severe contracture before surgery in the osteosarcoma. So in the end, actually 1 week after surgery, so we have to do the amputation above knee because of this case. These challenging cases, another challenging cases that we have to do the Zydits, whether ablations or salvage surgery. This case is actually with the recurrent giant cell tumor after extended curative 5 years before, actually had been done by me as well. So we'll review the clinical and imaging. This is the imaging, and this is the clinical. This is the imaging, actually the radiographs, and we perform the CT angiography. So from this, we decided to do the salvage surgery, and we perform the end block resection of distal femur, reconstruct with the distal femur implant. But at that time we did not soft tissue reconstruction like the reinforcement with the sartorius flap. So 2 weeks after surgery, there is actually there was the dislocations of the implants, and we have to do the open reduction with soft tissue reconstruction with using the sartorius flap, and also cast immobilization to improve the healing process of the soft tissue. This another implant that that should be used actually in the proximal tibia case. Actually, the patients comes late to our hospital from Kalimantan, so we think about the probability of the ablations. We cannot the surgery. This is the MR. So what we are doing is we perform the end block resections, yeah, and reconstructs with the proximal tibia implant and soft tissue reconstructions. After that, this is the imaging after surgery. The patients actually had the peroneal injury, but 3 months after surgery, the peroneal nerve will recover. This is the proximal femur. Sorry, this is the metastatic bone disease in the shaft of the femur from the ovarian cancer. So we are consulted by the internees. So what we are doing is we have our planning is to do the end block resection in the pathological lesions, and we resect the proximal femur and transfer to distal part of the distal segment femur to achieve longer of the remaining bone. And after that, we reconstruct with the ORIVE. This is the proximal femur segment. We ORIVE, and after that, we reconstruct with the proximal femur endoprosthesis from another implants. So regardless, actually, the variety of cases in this study, with actually mix up between the malignant and benign tumors. It means that the indication of salpage surgery could be used for the benign and malignant bone tumor. Regarding the for benign bone tumor, regarding the final diagnosis. And actually, the surgical technique regarding the limb reconstruction is significant improvement. Actually, our surgical techniques and resulting in less blood loss intraoperatively. So the better functions of the patients can be achieved. And of course, that we have the learning curve for our salpage surgery, especially for use the united implants. So why the patients are still or lately has the functional outcome? Because in the younger age, actually, it should be psychological burden with major surgery, and they are more reluctant to move and more for tolerance to join the rehabilitation programs. And from our detailed record of surgical techniques of the extensor mechanism reconstructions, 2 of 13 cases of the proximal tibia tumor still present with the knee extension difficulties, so requiring occasional using of the extensor support, but it is actually acceptable for the patients. So we have some challenges for the musculoskeletal tumor surfaces, especially for why the patients comes more late to our hospital because of the Indonesian culture. So many patients come to us with previously they come to the traditional helper or bone setter for massage, what kinds of the problems, pains around of the joint. So the things about the sprain and geographic restrictions due to the archipelago and also the ocean spread to the islands. So this is actually big factor, especially for the patients very far from the centers, and also the socio-economic problems, including the education. So that's why they this factor actually causes of the why the patients comes late to our hospital, and also disciplines in making medical appointment, in developing the rehabilitation program. So it should be why the functional outcome still poor or fair in the several months after surgery. So for the summary, that we have some challenges in the healthcare musculoskeletal tumor, how to our patients comes earlier stage because of many factors. Tumor prosthesis for the reconstruction has gained more and more acceptance for the patients, hospital, and also for our governments. And modern modular replacement system as actually it has the stage of the art how to achieve a good precision for the implant, and got an excellent result were noted, although several devastating complications also recorded influenced by the pre-operative conditions of our patients. Thank you for your attention.
My topic for today is tips and tricks in endoprosthesis replacement. I've divided this talk into the different types of replacement. We'll start off with the proximal humerus replacement. then the proximal femur, distal femur, total femur, and finally the proximal tibia replacement. In proximal humerus replacement, we generally do a hemiarthroplasty rather than a total joint replacement. A proximal humerus endoprosthesis generally acts as a spacer. During resection of proximal humerus tumors, the joint capsule is normally sacrificed, therefore we need to reconstruct back the joint capsule. Furthermore, we need to preserve the short rotator cuff muscles, which consist of the supraspinatus, infraspinatus, teres minor, teres major, and subscapularis, which will be reconstructed back to allow secondary stability of the shoulder joint. The deltoid plays an important role in the shoulder to preserve the curvature of the shoulder, to allow abduction and flexion of the shoulder. Therefore, during dissection, we need to preserve the axillary nerve, which is the main nerve supplied to the deltoid, and majority of the bulk of the deltoid. Biopsies that are done for the proximal humerus are normally done through the anterior fibers of the deltoid, and this biopsy tract is excised during the actual resection via the deltopectoral approach. This slide shows the proximal humerus that has been resected and the proximal humerus endoprosthesis. The items that we use for reconstruction consist of the polypropylene tube that is marketed by Implancast, which is known as the Tivira tube, and non-absorbable 2O Ethibond sutures. The Tivira tube is shaped like a stocking and is cut into two halves as shown in the video. Each half is then stitched to either side of the acetabulum. As you can see in the video, after stitching, the construct is stable. The implant is then reduced into the glenoid, and the limbs of the tibial tube is wrapped around the implant, one after another, as shown in the video. This allows a more accurate reduction of the humeral implant into the glenoid and allows a more secure reconstruction of the pseudo-joint capsule. Finally, the non-absorbable Ethibond 2 sutures are used to stitch the tibial tube down to the implant. This allows a very secure reconstruction. To this reconstruction, the short rotator cuff muscles and the deltoid muscles are stitched down to allow better stability of the shoulder joint and to allow movement of the shoulder joint. As you can see from the X-ray, the humeral head is well reduced into the glenoid. Next, we move to the proximal femur replacements. For proximal femur replacement, we generally use a bipolar articulation rather than a total joint replacement. This is because a bipolar articulation allows greater mobility and lesser dislocations compared to a total joint replacement. The hip joint is secured and stabilized by preserving the hip joint capsule, which is stitched around the neck of the implant using purse string sutures. In this type of resections, the abductor attachment to the proximal femur is normally sacrificed. There has been numerous attempts to stitch down the abductor mechanism down to the implant, but this usually will fail once the patient starts weight bearing and starts walking. There are some centers that use mesh to surround the implant and stitch the muscles down to the mesh, but this is generally not done in our center, as we believe the use of mesh will only lead to increased chance of infection. In cases where the hip joint capsule needs to be sacrificed, as it may be involved in the tumor, we usually do a total joint replacement by using constraint cups, and these constraint cups are the ones that provide stability to the new hip joint. This is a recent publication in the Journal of Arthroplasty where they use a proximal femur replacement for cases of revision total hip replacement, and they found that the commonest mode of failure was dislocation, as they did a total joint replacement. This is another publication in the Journal of Arthroplasty that shows that proximal femur failures are more common after a proximal femur in a failed total hip replacement compared to oncology resections. This is probably because in oncology resections, we use a bipolar articulation, whereas here they are using a total joint replacement. Next, we move on to a distal femur replacements. For distal femur replacements, we generally use the medial parapatella approach. The lateral approach is used for more proximal resections. In distal femur replacements, we need to ensure that there is adequate remaining bone in the proximal femur to accommodate the implant stem without compromising the oncological margins. One of the commonest problems that we encounter in a distal femur replacement is aseptic loosening, and this is classified as a type 2 failure under the Henderson classification. In such cases, it is important to rule out septic causes of loosening. When we are doing a one-stage revision, we can use tests such as alpha defensin, which will help us determine the presence of infection. As we know, for cemented implants, cementation provides the primary stability of the implant, and secondary stability is obtained over time due to osseointegration of the implant and the bone. Aseptic loosening is due to the failure of this process of osseointegration. Aseptic loosening is due to the activation of osteoclasts by the wear debris via the macrophage activation. Aseptic loosening can be prevented by promoting better osseointegration between the bone implant junction by using hydroxyapatite collars, porous coated collars, by inserting bone graft at this junction, by inserting a periosteal sleeve over the implant bone junction, or sometimes by using a side plate that allows better stability of the construct. Next, we move on to a total femur replacement. The principles of doing a total femur replacement is a combination of a proximal femur and a distal femur replacement. As we are replacing two joints, both the hip and knee joint, a more constrained implant at the knee is preferred to allow better stability of the limb. The standard approach used for total femur replacement is usually the lateral approach. Finally, we come to the proximal tibia replacements. The two common challenges encountered in a proximal tibia replacement are 1. Reconstruction of the extensor mechanism. 2. As the proximal tibia is subcutaneous compared to the other sides, there's a higher chance of infection. These problems are solved by using a gastrocnemius flap. The gastrocnemius flap is used to reconstruct back the extensor mechanism and also to cover the implant to allow lesser chance of infection. The Birmingham group have shown that the use of medial gastrocnemius flap in proximal tibia replacements reduces the incidence of infection and also is considered a biological form of reconstruction for the extensor mechanism. We can also use a Prolene mesh to augment the extensor mechanism reconstruction, as shown by this paper published by the Ames group, where they have folded the Prolene mesh to form a tape, and this tape is stitched down to the patella tendon and looped around the hook of the implant and stitched back into the patella tendon. This is only possible in cases where the proximal tibial implant has a loop which allows the tape to be hooked around. Currently, we are moving more towards a patella ligament preserving surgery. This technique is only possible in cases where the anterior compartment of the tibia is spared. In this technique, the patella ligament is dissected in continuity with the deep fascia and the muscles of the anterior compartment of the tibia. As noted earlier, this is only possible if the anterior compartment of the tibia is not involved by the tumor. Finally, the extensor mechanism, which is in continuity, is anchored down to the implant. I would like to conclude my talk by showing you the fibrous capsule. This is the pseudo capsule that forms around the implant. It is essential to remove this capsule during cases of revision endoprosthesis to allow full range of motion. Thank you for your attention.
First of all, I would like to thank the organizers of this webinar for their kind invitation. I'm going to talk about 3 cases of primary bone tumors that were managed using USTAR 2 implants. I will focus on the challenges and the difficulties that we have met during the management of these tumors. The first case is a 70-year-old lady who presented with a 7 months history of pain and swelling of the right knee. As you see in these X-rays, there is a lesion in the distal femur, which is mainly sclerotic. This lesion deforms the lateral cortical bone. There is also periosteal reaction medially and anteriorly. There is an interesting lesion here proximally. It's an oval-shaped dense lesion which is passed on the cortical bone, from which it is separated with this radiolucent line. On MRI, there is a heterogeneous lesion intramedullary with extension to soft tissues, but also what is interesting here is there is a suspicion of intra-articular extension of this lesion. The neurovascular bundles are spared from this extension. So we have performed biopsy, and we have observed well-formed neoplastic bone trabeculae with fibrous stroma, and these are features of low-grade osteosarcoma. So in summary, we have a low-grade osteosarcoma of the distal femur with the suspicion of articular involvement. We have 2 challenges. The first one is diagnostic. Which kind of osteosarcoma is this? The second challenge is the treatment. Should we perform intra-articular resection or extra-articular resection of this tumor, taking in account this suspected intra-articular extension? And secondly, should we use chemotherapy or not for this kind of osteosarcoma? The differential diagnosis of this lesion of this low-grade osteosarcoma are fibrous dysplasia, but here the lesion is frankly malignant. And if we look to the WHO classification of osteosarcoma, there are 2 kinds of low-grade osteosarcoma: the central low-grade osteosarcoma and the parosteal osteosarcoma, which is a peripheral or surface osteosarcoma. In this case, we could think that this is a central low-grade osteosarcoma. But if we look carefully to the X-ray, this melon-shaped lesion passed on the cortical bone with this radiolucent line is typical of parosteal osteosarcoma. But how could be parosteal osteosarcoma with this mass or this large extension to the medullary canal? We think that it could be a differentiated parosteal osteosarcoma, and this is what to our opinion, the diagnosis. It's a parosteal osteosarcoma that is more likely to be differentiated. So we performed resection of the distal femur, intra-articular resection, wide resection, and this is the specimen of the resected bone, and we have reconstructed the distal femur using USTAR 2 implant for distal femur. This is the macro section of the resected specimen, and as you see, there are two lesions that are at the periphery of the bone, and these two lesions have low-grade osteosarcoma, typical of parosteal osteosarcoma, and the central part of the lesion, or the intramedullary part of the lesion, the tumor is of a high grade malignancy, and in this picture we see clearly the sharp transition between a high grade component and the classic low grade component of parosteal osteosarcoma, and these are features of dedifferentiated parosteal osteosarcoma. Concerning the articular involvement or not of this tumor, here we see clearly that the joint space is separated from the tumor by this layer of synovium. Although thin, the synovium is anatomical barrier, and it constitutes and our margins here are clearly safe. We have published a paper about surface osteosarcoma, and parosteal osteosarcoma is the most frequent subtype of surface osteosarcoma, but it remains, although rare. The mean age of patients is about 25 years, and females are more frequently represented. It's a slow-growing lesion, and it remains for a long time asymptomatic. On the radiology, the parosteal osteosarcoma is typically presented as a melon-shaped lesion, dense lesion, which is pasted on the surface bone, from which is separated by this radiolucent line. The medullary canal is not involved in the classic parosteal osteosarcoma, as you see here also in the macro section. And on histology, it's typically a low-grade osteosarcoma, and it is fibroblastic. This is the classic parosteal osteosarcoma. Sometimes the classic parosteal osteosarcoma progresses in malignancy, and this invasion of the medullary canal, and in these cases we have to suspect dedifferentiation, and in dedifferentiation we have both components, the high grade one and the low grade one. The treatment of parosteal osteosarcoma, regardless the differentiation of the cell tumors, is based on surgery, and we have to perform wide resection as a goal. Some authors recommend chemotherapy as adjuvant only in the differentiated parosteal osteosarcoma. The second point to discuss in this case is the joint involvement in bone sarcoma, which is one of the most challenging points to assess before tumor resection. In 2009, we have presented during the ISOLS meeting a study about the reliability of MRI in the assessment of joint involvement in bone sarcoma around the knee, and the results were that sensitivity is 100%. However, the specificity of MRI in detecting joint involvement is about 41% only. So if we rely on MRI for joint involvement, we will do 60% of unnecessary extra-articular resections, which are technically more difficult to perform and with a poorer functional result. The second case is a 37 years old lady who was referred to us for a local recurrence of a giant cell tumor of the distal femur, which was treated 2 years before by curettage and bone cement. And this is the X-ray at presentation. And you see the osteolysis of the distal femur, but this huge mass in soft tissue extending posteriorly. So to our opinion, at this stage, there is no longer any indication for conservative treatment, and the resection is mandatory. How to do and how to manage this huge mass in the soft tissue? Is there any possibility or opportunity to or mean to improve the quality of the dissection? So for this patient, we used the denosumab for 6 months, and we have observed a well reossification of the lesion. This is the X-ray at 3 months, and this is the X-ray at the end of the courses. And you see the excellent reossification of the distal femur, which allowed an easy dissection and resection. The reconstruction was performed using USTAR 2 implant. And for discussion, so as you know, local recurrence in giant cell tumor can be as high as 50% of the cases. So it's the most difficult challenge that we face when we treat a giant cell tumor. And unfortunately, all adjuvants used and described in the literature failed to prove any efficacy to decrease this high rate of local recurrences. More recently, the denosumab has showed encouraging results. As you know, the giant cell tumor, which is an osteoclast-like cell, is activated by a cytokine released by the osteoblast, which is the rank ligand. And this activation of the giant cell tumors lead to bone resorption. Denosumab, as the suffix mab indicates, is a monoclonal antibody, and it will bind to the rank ligand and avoid the activation of the giant cells, so it inhibits bone turnover. So is it a miraculous treatment for giant cell tumor? We have used the denosumab for another patient who had a lesion in the distal femur, and we have performed curettage and denosumab for 6 months, and we have observed an excellent reossification and healing of the lesion. However, 6 months after we stopped the denosumab, there was a local recurrence. So this rebound effect is widely reported in the literature. Erani from the Rizzoli Institute published a paper about the use of denosumab after curettage of bone tumors, and he concluded that the denosumab may increase the risk of local recurrences in patients with giant cell tumors of bone treated with the curettage. The denosumab is recommended only if a resection is planned, but if we are going to do an intralesional curettage, we shouldn't use denosumab. The third case is also about local recurrence of a giant cell tumor of the proximal tibia, treated here also by curettage and bone cement. And in this case, we have performed a wide resection of the proximal tibia. And what is specific of the proximal tibia, or particular for proximal tibial resection, here is the reconstruction using USTAR 2 implants. As I said, what is particular to resection of the distal tibial, that we interrupt the continuity of the extensor mechanism. So we need to reconstruct the extensor apparatus to have an extension of the knee. And in this case, we use a flap, the medial gastrocnemius flap. We use this muscular flap to first cover the implant, but also to reconstruct the extensor mechanism. We make sutures of the patellar tendon to the edge of this flap. Patients postoperatively are immobilized for 6 weeks until this suture heals. And this technique gives excellent result for the function of the knee. So through these cases, we saw that the management of bone tumors is a multidisciplinary task and should be done in referral centers. Clinical, radiological, and anatomical correlation is mandatory for positive diagnosis. And we have also seen that MRI has low specificity in the assessment of articular involvement. Thank you very much for your attention. And if you have any question or comment, please feel free. Thank you.
Hi everyone, thank you for joining the webinar. My name is Matt Liu. I would like to introduce our new USTAR 2 system, which include rotating hinge knee and the low limb salvage system for the next 20 minutes. USTAR 2 is our second generation system. The first generation USTAR system was launched in 1996 with custom-made imprint. It was introduced as a more systematic modular mega prosthesis in 2004. The USTAR system accumulated more than 2,800 cases spanning 90 hospitals from 8 countries, including Taiwan, China, Thailand, Philippines, South Korea, Malaysia, Pakistan, and Indonesia, with 24 years of market. Based on a journal article in 2017, USTAR system demonstrated comparable survival rate to GMRS rotating hinge knee at mean and long-term clinical follow-up. Over the 2 decades, we collect clinical experience from our surgeons with the USTAR system. Here are 2 case reports which have been published. Those experiences help us to develop a safer and more durable USTAR 2 system. USTAR system was recently launched in 2020. This system consists of a rotating hinge knee and the low limb salvage mega prosthesis. It's designed for extensive reconstruction of the hip and knee joints. Here you can see overview of the main component and the series of accessories offered within the low limb salvage system. As for the rotating hinge knee, the following femur component and the tibia base plate with minimal bone resection are offered. For overview, it can be seen that the rotating hinge knee and the loading salvage post share the same tibia insert. Therefore, you can switch between two systems to meet the patient's need. Now, I would like to walk you through the design feature of our rotating hinge knee. Rotating hinge femoral component is pre-assembled with a hinge. Femoral accessory can couple with our PSA revision knee system, as they are identical. Our tibia insert and the base plate, on the other hand, have been redesigned with new tibia stem and ornament specially for this system. For the size matching, all 6 of femoral component sizes can fit size S and M of tibia insert. However, size S of tibia insert only fit tibia base plate size 1 to 3, and the size M of tibia insert only fit tibia base plate size 5, 4, 6. Here are some major design features of our rotating hinge. We are now going through those in more detail. The first feature is similar profile design. Hinge knee is designed with similar profile to U2 primary and the PS revision knee. It has the same AP and ML dimension, resection profile, and the box wise to allow interchangeability between system knees. The only minor difference is the condyle box depth of a PS and hinge knee. This difference is required to contain the built-in hinge mechanism. A benefit of similar profile design is to improve intraoperative flexibility. With a consistent AP-ML dimension and the resection profile, which will be easier for surgeons to switch between different constraint levels of implant during surgery. Another benefit is minimal bone cuts. Traditional hinge knee contain bulking hinge construct, which requires significant bone resection. This was a major concern for surgeons about efficient bone stock for potential revision surgery. For our hinge knee, the box wise is consistent with PS revision knee and the smaller name the conventional rotating hinge product such as Zimmer RHK or Smith-Nephew legend. Also, the posterior and the distal condyle thickness of the hinge knee are smaller than a formation the conventional product to achieve bone preservation. For second feature, hinge knee is designed with better load transfer. In some conventional rotating hinge knee, the hinge was designed to bear majority of the compressive loading. According to a literature review, value of rotating hinge mechanism need to replace hinge bushing up to 12% at a mean of 13 years follow-up. Therefore, hinge knee is designed with a condyle loading mechanism to decrease condyle stress on the polyethylene to prolong implant longevity. In addition, as a consideration of wear reduction, high-cross-link polyethylene is chosen as substrate for the tibia insert and the hinge bushing. A finite element study was conducted in accordance with ISO regulation to study the hinge knee condyle loading mechanism and its ability to transfer load efficiently during gait cycle. In our study, the results demonstrated that hinge structure does not interfere with actual load transfer. For third feature, hinge knee has a simple knee assembly. The total procedure of our hinge assembly just only 3 steps are required, including positioning the tibia insert, connecting the femur yoke and tightening the C screw. Compared to the hinge assembly procedure of Legion, our hinge knee only requires a single page and one instrument to complete the assembly, which allows our hinge assembly process to be more user-friendly and time-sparing. To ensure the C screw will not loosen or break out after long-term use, we adapt the patent spiral technique into the screw thread. This technique strengthens locking strength. Our last workers loading test demonstrated that under 5 million load cycle, the screw still retains stable in all components. The secure connection between the femur components and the tibia insert is not complete rely on the single C screw. It also relies on square-shaped connect, which comes from yoke adapt and the insert poster recess to help share the majority of the vast worker's torque and prevent insert spin out during knee motion. After reviewing the hinge knee, let's dive into our limb salvage system. Those 4 configurations assist major limb replacement, including the proximal femur, distal femur, plasma tibia, and the total femur. For proximal femur replacement, we provide standard and low-profile design. Both proximal femur components have a 50 degrees built-in convergence. Therefore, left and right options are offered. You can choose between a series of accessories, including segment, extension stem, and crown, depending on your clinical requirement. USTAR system is designed with a focus on preserving more bone for future surgery. Therefore, the minimum resection length of proximal femur is 70 mm, potentially preserving 10 to 40 mm more bone as compared to other grade. For distal femur replacement, the bust angle of femur bones is 6 degrees. The AP and the ML dimension of the femur component are 52 and 56 mm respectively. The tibia components share the same design as the hinge knee, including tibia insert, base plate, and accessory. The minimum resection length of distal femur is 61 mm, which again is relatively lesser compared to our brain. Also, the minimum thickness of the tibia component is 12 mm to preserve more bone than LPS and the GMRS system. If you desire to have a total femur replacement, you can combine the proximal and the distal femur components with an 80 mm bridge and segment. As for tibia, it also shares the same design as the hinge. Regarding proximal tibia replacement, we provide a specific proximal tibia component, and the AP and ML dimensions are 42 and 63 mm respectively. As for the distal femur, it shares the same design as the hinge knee. The minimum resection length of proximal tibia replacement is 87 mm, which is also superior to major market players. Here are the major design features of low limb salvage system. Again, we will look into those in more detail. The first feature, we have designed suture hole for following component to make soft tissue attachment easier. Considering the requirement for long-term fixation, we have applied tight plasma spray coating on the junction between implant and host bone to facilitate osteo integration. For second feature, in order to minimize leg length discrepancy, we offer in total 21 segment sizes, including a fixed segment length of 25 mm and the segment size range from 30 mm to 220 mm with 10 mm increments. While four are distributed near the junction in both AP and NO direction. For third feature, our long limb salvage system is designed with enhanced junction fixation. The junctions in this system have been reinforced with an anti-rotation hex design. This is not only enhanced total resistance, but help design component relationship, such as the divergence of the proximal femur and the anterior bowing of curb stem. In addition to connecting hex design, a pair of C-screws are used for secondary fibrillation at a taper junction. This technique can enhance fixation strength at the taper junction by threefold, as comparing to taper fixation only condition. For fourth feature, we will look at each stem separately. For cemented stem, we offer non-coated and standard design. Non-coated stem have a shorter extramedullary length for vena bone resection. Standard cemented stem is designed with titanium plasma spray near the junction to allow bone bridging with bone graft. In order to stem fracture, all stems are forged with copper alloy and have a yield strength twice that of USTAR cemented stem. Based on good clinical outcome with cementless stem in our USTAR system, we continue to offer full-coated cementless stem in USTAR 2 system. Because the cementless system is difficult to remove after implantation, therefore, we do not suggest to apply this implant to a patient with high risk of infection. Here is an overview of our spec table for stem, including straight and curved design. For stem lengths, we offer 100, 125, and 150 mm option for our cemented stem, and 150 and 200 mm option for our cementless stem. As for the stem diameter, only the cemented stem has a 9 mm option, while both the cemented and the cementless stem have a 11, 13, 15, and 17 option. For small or pediatric patients, USTAR 2 system offer an extra small size implant, and this is a special design system. Its femur component and the base frame are not compatible with a standard accessory. In addition, this system only offers a 12 mm tibia insert option. As for instrumentation, USTAR 2 system have in total 17 instrument tray, which can be tailored to address individual product and operation requirement. In addition, we have a choice of either a single or double data tray to meet the requirement of hospital or customer. To conclude, with the addition of our USTAR 2 system into United product portfolio, you can now have a more comprehensive total knee solution to meet your patient's need. Thank you.
Okay, thank you for 5 speakers for excellent talk. Thank you so much. So I think there is some questions in the list, right? So maybe we can answer the question first. Okay, so the first question is, I think that's for me. Dr. Lin Ted asked me about the size matching for the after we do the pedicle freezing. I think that's a very great question because we know the tumor will destroy the bone. So sometimes the condyle is disappear, or maybe the posterior condyle is disappear. And sometimes there is a lot of huge soft tissue mass. So that's all influence to evaluate the landmark of the bone. So I think when I do the size matching, there's something I can do. First, I think not too much tumor will destroy all the distal femur. Maybe only the medial side or the lateral side. So sometimes if the tumor destroy the medial side, we can evaluate the size by the lateral side. Or sometimes if the tumor destroy the epicondyle area, we can evaluate the size by the posterior condyle. I think that's a method. Another way is we can compare if the tumor is over the distal femur, I think we can evaluate the tibial side. Because we know the size is very good. So if the tibia size is 3, I think the femur size is 3. There's no problem. And the third method is we can check another side. Maybe the tumor is at the left side. We can check the right side and do the size measure before the surgery. And I think there's only one tip is if the size is between maybe 3 or 4 for the tumor, I believe we can choose 4 because the larger size we can cut the bone less. Then we can preserve the more normal bone. So I think that's my way to do the size matching for the distal femur. So I hope I have answered your question. Okay, and I think the next question is for Dr. Nori, right? Dr. Nori, Dr. Basu Kimi want to ask you about how do you evaluate the intra-articular involvement of the tumor. So could you answer that? Thank you.
Actually, it's very difficult to answer this question because we don't know the rules. Usually, MRI shows intra-articular invasion, and if we don't have a joint effusion clinically, we usually go for intra-articular resection. There is no rules, as I said, and we trust more than the experience, which is the lowest level of evidence-based medicine. There are no evidence-based for that. There is only the experience of the surgeon to determine. Some authors recommend to perform an intra-articular examination of the knee when we drape the limb. We start with arthrotomy and we check if there is intra-articular or if there is joint involvement. If it's the case, so we close and we change the drape and we perform extra-articular. But when we discuss with oncologic orthopedics during international meeting, we don't find the right answer for this question. So we rely more on the experience of the surgeon. But if the risk is high, it's more safe to go for extra-articular resection. We don't have an exact answer for that. It's very difficult to answer.
Okay, thank you. Okay, and there's another question for Dr. Wang. He mentioned about the extracortical bone bridge formation for the better longevity of the tumor prosthesis and the host bone. So, is there any speaker have some experience with this? Because this is also my question, because we in my team we do a lot of pedicle freezing or recycled bone. So for my case, I think less than maybe 5% of patients we use the mega prosthesis. That's the reason, because we worry about the early loosening of the mega prosthesis. So in my team, when the patient is maybe younger than 17 years old, or they have a better outcome, we are routinely use the pedicle freezing, use the biological reconstruction. So I know there's some new design from USTAR 2 that have some coating in the stem, right? And it could cause the better bone bridging. So Dr. Matt, do you want to answer this question? Do you have some animal study or some study evaluate the bone formation between the host bone and the prosthesis by the coating?
Actually, because USTAR 2 is based on USTAR 1 experience, so you can see the slide have some display about the coating area. If you do the bone bridge here, and you can see the bone formation maybe the 3 or 4 years later. So it's our experience. If you have any coating here, we do in the first generation we do the post coating. In the second generation, USTAR 2, we do the plasma spray. I think the coefficient is good, and the bone osteointegration is good. That's our experience.
Okay, so the same question may I ask Professor Sim and Dr. Fauzi and Dr. Nori. So did you routinely use the extra-articular bone bridging during your mega prosthesis?
I'll speak first. In our cases, normally we do not add in any bone graft, but what we try to do is we try to use a periosteal sleeve to coat over the bone implant junction. And the implants that we are using at the moment are the GMRS, which are all porous coated. But we also use implants from India, which are custom made for children, which are growing prostheses. And in those prostheses, there is no form of coating, rather a rough layer around the implant bone junction. And we noticed for those cases, there's excessive bone formation at the implant bone junction. I feel it has something to do with the instability, because in children, normally we put in all the implants uncemented with a smooth stem. And we find that over time, as we follow up, there will be excessive amount of bone forming at the implant bone junction, crossing, even going down to the femoral condyle. And you find that very, very encouraging, especially in children. Even if you look at cases of aseptic loosening, when you see the implants that are loosened, they tend to form a lot of bone around the implant bone junction, but that does not translate to osteointegration. Because despite the excessive amount of bone formation, there will still be movement, rotational movement between the implant and the bone. So actually, I wanted to ask Dr. Matt a question regarding very distal resections of the distal femur. When you do a very distal resection, as you know, the remaining stem is normally flat up. And when you try to put in your stem, sometimes the diameter of the stem is just slightly smaller than the femur, the canal of the femur. Does USTAR 2 have different diameters of the stem, the collar of the stem, to match the size of the distal femur so that there can be bone-to-bone contact?
Okay, actually our stem diameter in the proximal side is proportional by size, but sometimes it's smaller than the canal. So maybe we can provide the custom-made, just like an O-ring, you can offer to the larger canal patient. Yeah, it's our solution.
And Dr. Fauzi, what's your experience for that, for extracortical bone bridge?
Yeah, Dr. Wu, thank you. We just review from the United implant actually that we use. Yeah, we normally put the bone graft between the porous coated and to the host bones. So some cases actually that we review 5 years, 6 years, there is the good, I mean, the stability between the stems and to the host bones. But some of the cases still show the some loosening. So, but the problem is the I means that we still use the another medicines such as the biphosphonate to improve the stability of the implant and the bone. This is my small cases appearance from the host bone junctions.
Okay, thank you, thank you. And Dr. Nori, could you tell us your experience?
We usually use prosthesis which have the HA coated color. It's one of the criteria to choose our implants because from the literature it is demonstrated that it improves the stability and decrease the loosening of the implant at long follow-up. But we have never used the periosteum flap because in this case we have to resect more bone from the safe bone because the limit of our osteotomy should be at 2 centimeters from the tumor, and we have to resect the periosteum as well. So if we need to leave flap from the periosteum, we have to resect 1 centimeter more from the cortical bone to have 1 centimeter of periosteum flap. So I don't have the experience to save the periosteum flap because I will cut more bone. But for the HA coated color, it's a major criteria for choosing the implant.
Okay, thank you. And another question from Professor Casey Wang again. Casey Wang asked us how to choose for the cemented or uncemented stem for the makeup prosthesis. So maybe I can answer first. But for me, I don't use the makeup prosthesis. I use the BPC. So you know, for our bone is recycled bone is freezing or irradiation. So in the past, I always use the cemented stem for the recycled bone. But recent months, because we do the pedicle freezing, and sometimes we found the bone start to oozing after thawing. That means before freezing, the canal is connect with the recycled bone and the host bone. And because we do not do any osteotomy, so after thawing, the bone is revascular very quickly. So some cases we try to use the cementless stem for young kids, because you know in the past we do some case for the cemented, for maybe long stem cemented for kids. But if we met some problem like fracture, like infection, I think that's a mess. That's difficult to handle that. So currently we start to try some cases. If we think the vessel is recovered quickly, so we start to try to use the cementless stem. And how about the result? I don't know. Maybe we got to follow for a couple years, and then we want to have a report to you. So any speaker could answer Casey Wang the question, what kind of stent you choose, cemented or cementless, and why? And Professor Singh?
In Malaysia, we do not have the option of using cementless stems because none of the implant companies bring in cementless stems. So we have to use cemented here.
Okay, Dr. Fauzi?
Yeah, until now, like the Professor Vivek mentions that we always use these cemented stems for all cases, but I think even though with the cemented stems, some cases achieve more than 10 years follow-up without any loosening. But I mean, this is for the adult patients, Professor Wu. But I think there are some cases that we have, especially for distal femur endoprosthesis. Yeah, from this, our review that the tip of the stem of the distal femur endoprosthesis hit of the anterior cortex of the femur. So in several years of follow-up, so it will produce the pain of this case. Yeah, I think this is the problem that we discussed with the Thomas from United. So to improve the designs of the stems, number one is designs of maybe the locations of the stem in the center of the United implant for distal femur, or use the design curves. I am happy that right now the United have the longer stem and also the curved stems of the distal femur and also the cementless options. Dr. Wu, this is.
Okay, and Dr. Fauzi, I want to tell you a secret.
Yes.
Even you can custom made. If you want a longer stem or a thinner stem, you can ask Matt. Maybe they can send you a custom made implant stem for you. Matt, is that okay?
Okay.
Yeah, of course, of course.
Okay. And okay, Dr. Nori, how about your experience for the stem choose?
From the literature, there is no evidence about the superiority of cemented or uncemented stems. But my own opinion is that the problem with the cemented stems, that in case of revision, we have a problem with the cement over the edge of the stem. So we have difficulty to remove all the cement around the bone canal. But this is my own opinion. From the literature, no difference.
Okay, thank you. I believe Professor Casey Wang is a very, very, very experienced surgeon for the tumor. So I think Casey Wang should have his answer. So I think this is a very important topic. So maybe United Company or maybe you need to invite Casey Wang to have a speech for us and teach us how to choose the prosthesis and how to choose the stent. I think that would be very grateful for our audience. Okay. Okay. So if no any question, I think we have covered everything on the list. And if no one has anything else to add, then I think I will wrap this up. So again, I want to yes.
Sorry,
yes.
May I ask to Dr. Metz?
Yes, please.
So some cases that we had, I do not know actually the new generations from the United Company, because normally we use the implant from United until 2000 and in the end of 2014. So I do not know the new generation, especially for distal femur. I saw the presentations from Dr. Max Liu that there is new designs for distal femur. So the problems in the previous generations, actually the thick of the condyle of the femur is too thick. I mean, sorry, this is for the proximal tibia. So if we cut 2 more, so I think this is the produce the bone loss for distal femur. So is there from the new generation, if I am not mistaken, you designs that the distal femur for the proximal tibia endoprosthesis is relatively thin or close to the look like the normal. I mean the thickness is normal of the total knee replacements. So isn't it, Dr. Matt? Maybe your comment for my questions.
In tibia side, the minimal bone cut is 12 millimeter, and in the tibia, femur side, just like a hinge knee, just posterior is a 9 millimeter cut, and the distal in 9 millimeter cut. So it's consistent with our PS revision knee and the U2 primary knee. So you can combine the smallest femur component and the tibia component. We call this system is a hinge knee. So it's a minimal bone cut. May I answer your question?
No, I mean for the proximal tibia endoprosthesis, the distal femoral component. I mean, in the previous generation that I know, the thickness of the condyle of the femur is more than 2 cm. So this is the problem for us, because if we cut more, this is produce the problem bone loss in distal femur. So is there any new designs for the megaprosthesis proximal tibia for the corporal femoral component?
Okay, sorry, I am come from the United the UPD. I'm the DBJO. I think you want to know this is. Sorry, I think you want to know this. If use the proximal tibia in distal femur cutting, you should in the USTAR 1. You should cut the 24 millimeter is distal cutting, right? In the first generation, but in the second generation, you don't need like this, because this profile like primary knee. So in proximal tibia, femur distal, you just cut 9 millimeter, and the distal posterior cut 9 millimeter. It's very less. It's like a primary cutting. Or in the distal femur, if you do this proximal tibia cutting, you also like primary cutting. You can cutting the minimum cutting. In medial side, we call is 2 millimeter. Lateral side, you can cut 9 millimeter. It's a less cutting. It's in primary, like a primary cutting. And then insert. Less minimum is 12 millimeter. So you in the case you can cut this less cutting and use 12 millimeter. In Taiwan, in Dr. Professor Wu also like this. So we cutting is primary cutting, but you can use a 12 millimeter insert, no problem. In our case, we almost in this 2 years already finished the 500 case. It's like this to use, it's no problem. But if you want use a cutting as 12 millimeter, also it's no problem. It's all work. So we in the instrument we have a 9 millimeter cutting, or you can choose a 12 millimeter cutting. Don't worry, we all have the issue in our instrument. Thank you.
Can I ask a question?
Thank you so much.
Yes, in the first generation, when we went in for revision to change the bushings, we were told that the bushings are not available as separate items. So for these cases, we had to replace the entire distal femur, because in your first generation, the bushings come intact with the distal femur. For your second generation, are the bushings packed separately, so that when we go in for revision for bushings, we can just change the bushings without changing the distal femur component.
Okay, our answer this is okay. Bushing and the hinge, and in first generation is a hinge locking in the femur. You should change the hinge with the bushing, the tibial bearing side. But in second generation, distal femur, we use the example is rotating hinge. His distal femur have adapter with rotating hinge. So if you have a revision, you don't need to change bushing. You don't need to change the adapter. You just can change insert. But insert with rotating the bushing is come together. So if you want a revision, you take up the insert with the bushing adapter all over and change insert to new insert in the processes. That is our work. So example, if you before you use a second generation is a 12 millimeter insert, but he will you should change. Maybe it should more thicker the insert. You can take up the insert with the bushing and change the new one in the processes. That's all. You don't need to change all this component or the tibial component. Yeah, second generation you can part, you change it about this. Also, you can revision distal femur, rotating hinge, change it to distal femur. Also, you can do it. So don't worry about the processes. All of this modular type, okay, all of it you changeable. Don't worry.
Then, Professor Wu, just a quick question before you go. You showed us the freezing tube. Is it something commercially available or is something only available to yourself?
Oh, that medical device is available in Taiwan. So Taiwan now have some, I think Taiwan there's some license. But I think if that is, maybe we can try to use it in other countries. So if Dr. Singh, if Professor Singh, you have interest, you can contact to me. I will ask the company to do some communication.
And the other thing I noticed, after freezing your tumors, you don't debulk the tumors before putting in the plates and all that. You leave the tumor as it is.
Yes, we leave the tumor there. But sometimes if the tumor soft tissue mass is too much, I will cut some part of the tumor. Otherwise, if the tumor is inside the bone or just small, we just leave there. Because according to Professor Tsuchiya, the necrotic tumor after cryotherapy, there is some cryoimmunology. Yes. So now we just want to leave the tumor there and see if there any some response abscopal effect to kill the tumor or some metastasis lesion.
So for these cases, if you are followed up over a long period of time, does the bone remodel back to normal?
You mean the bone remodeling?
Yes, that's it. Because it will be expanded due to the tumor.
Yes.
Over time, do you find that it remodels back to normal size?
Okay. I think that there is some remodeling have the two way to think that. One is the junction between the freezing bone and the host bone. I think for the junction, there's a creeping bone ingrowth is about 10 months. So in average, the 10 months, the bone will union. But for the whole bone, maybe 20 centimeter or 15 centimeter, I think that's just some partial revascularization. Because according to Professor Tsuchiya's paper, after maybe 8 years or 10 years of forgot, there's just part of the tumor revascularization, and other bone is still dead bone, but they maintain a very good stability and structure. Thank you. So okay. So I want to thank you for taking time out of your busy schedule to be here today. So if anyone has any questions about anything we discussed today, please free to contact United staff. there were 4 to 5 of us. So see you next time in the near future. Okay. Thank you.
Okay, bye-bye.
Bye all. Thank you so much.